Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to both understand and perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics that we all have to engage with in daily practice. Valvulopathies, cardiomyopathies, systolic and diastolic function and dysfunction, and also the new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in imaging and echocardiography, and I will guide you through clinical cases and talks from my clinical experience addressing a wide range of echocardiography topics. My imaging, the images that you will see in my talks, are all based from my experience in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is not only a YouTube channel, it is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage of the website, echobyweb.com. Up here in about, you will find my credentials. Under Atlas, you will find 2 atlases of imaging, transthoracic and transesophageal. It's work in progress. Under Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, the Montgomery plaque classification, and analysis and quantification of the left ventricle, the mitral valve. And then you will also find formulas and calculations, guidelines, references, an example of a complete echocardiographic examination. You will also find here online calculators, which are Excel spreadsheets on the website with which you can interact, and you can make a lot of calculations, stroke volume through the valves, and you can find the indications for valve surgery based on the latest guidelines, European guidelines, and you can find also flowchart for the calculation of diastolic function from the latest recommendations. And this is the QR code with which you can access, for example, if you have a cell phone. The topic of these series of talks, which spans over 5 videos, and this is the second video, is the analysis of left ventricular systolic function and dysfunction in the real world. This is, of course, a basic approach to this topic, which is quite large. Now, all the talks assume that you have a basic understanding on how to perform 2D mode and Doppler continuous wave, pulse wave, and tissue Doppler measurements. And however, you will find in the website echobyweb.com that I've just mentioned a large quantity of materials on how to perform these measurements. And this is the outline of this talk on left ventricular systolic function. We begin with an introduction and definitions. Then we move on to physiopathologies and define the determinants of systolic function. We analyze the pressure volume loop as constructed invasively, and we see how invasively we define left ventricular contractility. When we move on to the aims and the qualitative evaluation of left ventricular systolic function, and then the mechanical function of the left ventricle through ejection fraction, and how to perform stroke volume assessment and cardiac output. And then we have the echocardiographic estimation of left ventricular contractility using isovolumic phase indices like the noninvasive dP/dt from mitral regurgitation and the Myocardial Performance Index or TAE index. And we end with the analysis of left ventricular longitudinal function using tissue Doppler because strain analysis will be the topic of a whole new another video. And these are how they are grouped in the 5 videos. And this is video number 2, from physiopathology and the pressure volume cardiac loop to echocardiographic qualitative analysis of left ventricular systolic function. So the interplay of pressure and volume during the cardiac cycle is the starting point when analyzing cardiac physiopathology. This interplay during the cardiac cycle creates a left ventricular pressure volume loop, the one that you see here. Let's see how the loop is created. You have to measure simultaneously and invasively left ventricular pressure here and volume. This is obtained by introducing in the left ventricular cavity a conductance catheter, which the conductance catheter measures the volume continuously, and it has on its tip a pressure gauge transducer which measures simultaneously pressure. And you see here the volume curve and a simultaneously obtained pressure curve. And on this Cartesian graph here on the right, pressure and volume are plotted simultaneously and respectively on the vertical axis, the pressure, and on the horizontal axis, the volume. And this creates a pressure volume loop, as you see here, as it is instantaneously created. And here below the pressure tracing, you have the first derivative of the pressure curve. The dp on dt, and on this first derivative tracing you see two peaks. The red one, the positive dp on dp during isovolumic contraction, the green one here, the negative dp on the maximum dp dt during isovolumic relaxation. And these are two measures widely used in invasive cardiology to estimate contractility, the positive peak, and to estimate relaxation, the negative peak. However, both of them, they are not real gold standard measures of contractility and estimation. They only measurement. They only estimate because they are still considered load dependent. And the pressure volume loop has four phases: 1, 2, 3, and 4, which are described down here. As we have seen in the previous slide, for the timings of the cardiac cycle, we start here arbitrarily at end diastole with the mitral valve closure, which is down here, which is caused by left ventricular contraction, and then we have a rapid rise in ventricular pressure with mitral and aortic valve closed until the aortic valve opens. And this is the isovolumic contraction. We have a rapid increase in pressure. As we said here, we can measure the positive dp on dt. Left ventricular volume is invariant. The second phase of the loop is ejection between aortic valve opening and aortic valve closure with ongoing myocardial contraction. During this phase, the left ventricular ejects volume. You see here that the volume decreases while pressure increases a little bit. You see it again here. The third phase is isovolumic relaxation, which starts with aortic valve closure and ends with mitral valve opening. You have an abrupt decrease in left ventricular pressure. In this phase, you can measure negative dp on dt. There is a rapid fall in pressure, as you see here, and a substantial invariant left ventricular volume. The final fourth phase down here is left ventricular filling. Left ventricular filling between mitral valve opening and mitral valve closure. And here, left ventricular pressure increases a little bit until end diastolic pressure, and left ventricular volume increases substantially until a left ventricular end diastolic volume, which is left ventricular preload. Now, we have said that positive dp on dp is only an approximate estimate of left ventricular contractility. So which is the gold standard measure of ventricular contractility in invasive cardiology? The gold standard invasive method to define left ventricular contractility is through the pressure volume loop of the cardiac cycle. In the Cartesian plane here in A, you see a normal cycle in red. This one, we have described it in the previous slide. It's this one. Down here, the white dotted, which is part of the normal cycle, and the white line, they describe left ventricular compliance and how to measure it. You will find an analysis of left ventricular compliance and diastolic function in general in this channel, in the talk about left ventricular diastolic function and the dysfunction. Now, still in this Cartesian, in this panel A, the dark green loop that you see here describes a patient with a reduction in cardiac output. In fact, the area of the loop is smaller than the area of the normal loop, and you have a reduced ventricular compliance. We will talk that in depth. We address that in another talk, and reduced left ventricular contractility. Now you can see the reduced contractility by this yellow point up here, the ES and systolic volume 2 at aortic valve closure. You can see that this yellow point of reduced contractility is positioned on this white line, which is shifted to the right and downwards compared to this other dotted line of normal contractility. So end-systolic volume 1 of the normal loop is the end-systolic point is on this straight line. The reduced contractility loop has an end-systolic point on another line, and the shift of this line defines a shift in contractility, and the position on the line on the Cartesian plane defines contractility. So about contractility, I mentioned single points, the end-systolic volume 2 and the end-systolic volume 1, the yellow dots, and I also talked about lines. So is it possible to define contractility just by defining a single point on this Cartesian pressure volume plane? Unfortunately not. It's not this simple, even with invasive measurements. Contractility cannot be defined by single pressure volume points, but the contractility is defined by a family of points which describe a line in this Cartesian plane. So how are these different lines describing contractility constructed? These lines are defined by, as we said, a family of points obtained by varying, for example, left ventricular preload, but you could also change afterload. The variation in preload is obtained, for example, by infusing volume in an experimental situation in an animal, as it was done here in graph B, or by, for example, creating a depression around the lower limbs in a human subject, which causes a recall of blood volume from the thoracic blood pool and thus reduces left ventricular preload. So in humans you would reduce preload, in animals you would increase preload. In both cases you obtain a family of loops, as you can see here on the panel B. So in the experimental case in animals, as we see in B, by infusing and increasing blood volume, we obtain an increase in filling of the left ventricle with multiple end diastolic points, and we produce a family of pressure volume loops which increase in area because we increase preload. This relates to the Frank-Starling law of the heart, which relates preload and stroke volume, but we will talk about this later. But simultaneously, we are also recording a series of end-systolic points at aortic valve closure. These points here, this AC, 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 and all these points are at end systole, and they are characterized by increase in volume and increase in pressure, secondary to the increase in blood volume pool that we have created experimentally. Note that all these end systolic points fall along a single line, the red dotted line that you see here, and a straight line. Both the slope and the position of this line on this Cartesian pressure volume plane define myocardial contractility. So we have two numbers that define the contractility, the slope and the position in the plane of the slope. This is the end-systolic pressure-volume relation that defines contractility. Now, compared to normal contractility, which is the red dotted line in this example, a reduced contractility will be defined by this, for example, yellow dotted line, which is displaced, shifted to the right and downwards. So this reduced slope and shifting to the right in this Cartesian plane defines reduced contractility. And this loop here has also a smaller area with a smaller stroke volume. Since a straight line is defined by at least 2 points, it follows that a single measurement of pressure and volume cannot define contractility by definition. However, in the clinical setting, with echocardiography, a change in end-systolic volume is often used to estimate a change in contractility, not absolute contractility, but a change in contractility when the other determinants, like the pressure, the preload, and heart rate, are unchanged, for example, in the follow-up of a patient. Thus, in echocardiography, in the same patient, an increase in end-systolic volume tends to suggest a reduction in myocardial contractility, while a reduction in end-systolic volume per se would suggest an increase in contractility. However, it is not possible in a clinical setting to compare contractility between different patients using only end-systolic volume. Now here in panels A and B, you can see the different effects of preload, afterload, and contractility on the ESPVR, which is the end-systolic pressure-volume relationship. As you can see in panel A, an increase in preload from the baseline blue loop to the green increase in preload loop, you have increase of the area, thus an increase in stroke volume, and you have an increase in preload. The end diastolic pressure volume point shifts from here to here. Please note that in this increase in preload, for both loop, they both stay on the same end systolic pressure volume point, so contractility doesn't change. And then in contrast, we have this red pressure volume loop, which characterizes an increase in afterload, for example, increase in the arterial blood pressure or the development of aortic stenosis. And you have a shift upwards of the end systolic pressure volume point, but still it stays on the same contractility line. In this case, stroke volume tends to stay unchanged or maybe decrease a little bit. But in both cases, the ventricular contractility is unchanged because all the different end systolic pressure volume points, they all stay on the same unchanged contractility, this orange slope. In contrast, in panel B, we can see what happens when contractility changes. In this case, when it is reduced. For example, we have a reduction in contractility due to acute ischemia or myocarditis. So we have a baseline orange loop here, and we have the reduced contractility blue loop here. So with reduced contractility, we shift from this line to this other line. The E on ES parameter, which defines the slope, changes, is reduced, and you can see that the slope changes, and you also have a shift of the slope towards rightwards and downwards. This defines the decrease in contractility, and you see also that the pressure volume blue loop with decreased contractility also has a reduced stroke volume. So a change in contractility changes the position and the slope of the contractility line of the family of end systolic pressure volume points, whereas changes in load do not change contractility because contractility is load independent. So not only the slope of the end-systolic pressure-volume relationship, these different slopes, defines contractility. There is another parameter which is V on 0, and this parameter describes end-systolic volume when end-systolic pressure is 0. So it's the intercept of the line on the horizontal axis. And this graph plots end-systolic pressure against end-systolic volume index, so end-systolic volume divided by body surface area. And data is presented for 3 distinct groups. For each one there are 2 end-systolic pressure volume points. And the 3 groups are Group A, which is normal subjects, and B and C are dilated cardiomyopathy patients with increasing levels of dysfunction. The figure also shows here on the right side in the table average values for the slope M and for the intercept V on 0 for the different groups, and you can see that with compared to the Group A normal subject, increasing this dysfunction, so increased reduction in contractility, you have a decrease of the slope from 5.4 to 2 and then to 1.4, and an increase in the V0 intercept from 32 to 40 to 100. So decreased slope and increased shift to the right on the pressure volume graph. In this other graph, you see plotted both the exponential and diastolic pressure volume relationship here in red, and the linear and systolic pressure volume relationship. In blue, the contractility, in red, the compliance of the ventricle. So all the end systolic pressure volume points C, C1, C2 are all on a straight line, the blue line, which defines contractility, and all the end diastolic pressure volume points D, D1, etc., they stand on the exponential red line, which define myocardial compliance. And then we have the A, B, C, D normal loop with normal contractility and normal compliance. And then we have the A1, B1, C1, D1 loop, which describes a ventricle with the same ventricle but with an increased preload. You see that the change in preload from A to A1, but still a ventricle which stays on the same compliance exponential curve and on the same contractility straight line. So this is an increased preload and an increase in stroke volume due to the Frank-Starling law, as we will see later. And then finally we have the A2, B2, C2, D2 loop, which describes a ventricle which has a further increase in preload up to from A to A1 to A2, still on the same compliance curve, and an increased afterload because we go from C to C2. In this case, the ventricle, this area here, is reduced. There is a reduced stroke volume because this ventricle has reached its preload reserve, which is A2. It cannot increase further on the red exponential line of compliance. The only way that the ventricle could increase its preload is by remodeling, so and going into pathology, and so changing its compliance. Moving forwards, we have the systolic function afterload relation, and this represents the inverse relationship between ventricular afterload here on the horizontal axis, in this case we have end systolic stress, and ventricular function on the vertical axis. This is a very old graph, so there is fractional shortening and mode fractional shortening, which shouldn't be used anymore, and I put here ejection fraction, biplane ejection fraction, which is today's standard for left ventricular mechanical systolic function. The slope of this relationship, which is the solid line in the middle here on the graph, also defines myocardial contractility, the slope and the position on the pressure volume graph. There is so an inverse linear relationship between systolic mechanical function and ventricular afterload, and this relationship is independent of preload. Again, as is in the end systolic pressure volume relationship that we have seen in the previous slide, contractility is defined both by the position of the line on the graph, this straight line, and by its change in position. So a left and downwards shift of the line like this defines a change in a reduction in contractility. So the patients here in the red oval, whereas a right and upwards shift of the line defines an increase in contractility. This would be the dots here in the blue oval. So in a patient with a reduction in contractility that goes from here to here, for the same afterload on the horizontal axis, we will see a reduction in systolic function here on the vertical axis. Note also that independently of preload and with unchanged contractility, so staying on the same line, a reduction in afterload, so moving up the line, will increase systolic function, whereas an increase in afterload moving down this straight contractility line, we will have a reduction of ejection fraction. Ejection fraction, so, is quite dependent on afterload. So from this relationship, it also follows that a single measurement of ejection fraction or a single measurement or subsequent measurements over time in a single patient cannot determine myocardial contractility. We must also take into account preload, the endostaltic volume, and the afterload, so the blood pressure measured at the time of the examination. This is very important to remember in routine practice of echocardiography. And finally, we see here on this slide the Frank-Starling's relationship or role. The left ventricle can be seen as a pump with an input and output. The input is left ventricular preload filling pressure. You can see it on this graph here on the horizontal axis, and an output, which is cardiac output, which is stroke volume multiplied by heart rate, and stroke volume, you can see it here on the vertical axis. Now, the relationship between the input, the preload, and the output, the stroke volume, is represented by the left ventricular function curve, this one, these curves here in red, which define the Frank-Starling relationship. Again, as we have seen for the other relationships, the pressure volume, systolic pressure volume, and systolic function afterload relationships, the contractility here is defined by the position of the line on the stroke volume preload graph. And this relationship states that stroke volume changes as a function of ventricular preload. And a downwards and rightwards shift of this curve indicates a reduction in myocardial contractility. So this would be a normal curve, and this curve here shifted down to the right is reduced contractility. When contractility is reduced, an increase in stroke volume can occur only at the expense of an increase in preload, in filling pressure, so an increase in filling pressure sustains an increase in stroke volume. Or you can say the stroke volume occurs at the expense of filling pressure. And when the ventricle fails, as in advanced heart failure, this curve flattens out, which means that even a major increase in filling pressure, so with a very high expense in pressure, will not increase further the stroke volume. Let's look now at an example of the preload dependence of stroke volume, or the Frank-Starling relationship, in daily practice with our echocardiography. This is a pulse Doppler interrogation of left ventricular outflow. This is the time velocity. The best method we have in echocardiography to measure stroke volume. The first heartbeat that you see here on this panel in A, this time velocity integral here is the baseline stroke volume. The following beat that you see in B is a premature beat with a marked shortening of the previous diastole, which is this white line here, which produces a marked reduction of preload and a necessary following marked reduction of stroke volume, which is this time velocity integral here. You see a very marked reduction. All this according to the Frank-Starling's law. So in summary, the left ventricular pump function depends on its filling, so its left ventricular diastolic function, and emptying its systolic function performances. Stroke volume is the difference between end diastolic and end systolic volumes, preload and end systolic volume, whereas ejection fraction is stroke volume normalized divided by end diastolic volume or preload, and it follows that stroke volume is the end diastolic volume or preload multiplied by the effective ejection fraction. Consequently, stroke volume depends on the conversion of the filling pressure of the left ventricle to preload, the end diastolic volume, the diastolic performance, and the ensuing creation of stroke volume from end diastolic volume or systolic performance, as we have seen previously also in this graph. Now let's look at the aims of the echocardiographic evaluation of left ventricular systolic function. And these are the aims. So to begin with, in the parasternal long axis view, we have some tools, as we will see, to evaluate left ventricular systolic function using a pure qualitative approach. Then we have a global left ventricular mechanical function, which includes evaluation. Global evaluation means both along the radial and longitudinal contraction vectors, and this is measured today with biplane ejection fraction, combining the 4-chamber, the apical 4-chamber, and 2-chamber views. And then we have the evaluation of left ventricular stroke volume and cardiac output, which is very important. It gives a different information from global mechanical function, and so its measurement should complement the measurement of biplane ejection fraction. And this is done with the best method to do it is pulse Doppler of the left ventricular outflow tract. And then we have the estimation of left ventricular contractility. We cannot measure it with echocardiography, non-invasive method, but we can estimate it, as with all the limitations involved, as we just saw talking about physiopathology. And we can do this with the end systolic volume index, as we said, in the same patient during follow-up, and using the this Isovolumic index with this, which is the Myocardial performance index, a dimensionless index, also known as TAE index. All these parameters combined look at what we could call the emerged, the clinical systolic function that we assess on a routine basis. But we also have the evaluation of what we could call the submerged subclinical systolic function, which is that provided by the evaluation of left ventricular longitudinal function. So one of the two main vectors, the radial and the longitudinal. And this can be evaluated with M mode or 2D as a displacement of the base of the heart. With tissue Doppler, in this case, we evaluate the velocity with which the base of the heart moves. The best method, of course, is wall deformation or strain analysis. It is also important to consider that none of these measurements replace the others. They are all complementary. So one thing is mechanical function, another is stroke volume, another is the estimation of contractility. We have just studied that with physiopathology. And still different is the analysis of longitudinal function, which does not replace the global function. It's a complementary analysis. And don't forget stroke volume, which when stroke volume declines, for example, that means that you are losing your patient, which a declining stroke volume means a significant reduction of prognosis. As we have seen, we have today several tools to assess left ventricular systolic function using different modalities. Historically, we have moved from M mode to 2D ejection fraction and Doppler stroke volume to 3D and finally to systolic wall deformation and systolic strain. There is no doubt that one-dimensional methods as fractional shortening should no longer be used, and ejection fraction should be no more derived from linear measurement, unidimensional measurements. And a quality-based echocardiographic examination uses biplane 2D ejection fraction or 3D ejection fraction to evaluate mechanical systolic function, and pulse Doppler or 3D volume to measure stroke volume. It is true that in principle 3D biplane ejection fraction is more accurate if the ventricular geometry is irregular, but using 3D in the community setting or in a smaller hospital is still not feasible in many geographical settings, and a 3D probe can be quite expensive. In my opinion, once that the necessary learning curve has been digested, biplane ejection fraction remains the optimal method for measuring left ventricular mechanical systolic function in all settings, as it is accurate, it's reproducible for clinical purposes. But the fundamental prerequisite is that the operator himself be accurate and reproducible. Systolic wall deformation analysis, strain analysis that you see here in this lower right panel will be discussed in a forthcoming video on this channel. Is a relatively new methodology which has several advantages. It is semi-automatic, accurate, very reproducible, and provides both a global but also a segmental assessment of left ventricular systolic function. In the second case, the segmental case, still underused, it allows for an objective parametric assessment of the regional function for the first time in echocardiography. As you can see in the lower right panel, each of the curves here represent, in these different views, represent the systolic function of one of the 18 ventricular segments. You see in the 4-chamber, 2-chamber, and 3-chamber views. When performing strain analysis, 2D quality, however, is very important, like for 3D. But unlike 3D, strain analysis its feasibility is much greater. It comes up to 90%. Again, it is important to stress that systolic wall deformation analysis does not replace ejection fraction. They see different things. Ejection fraction is global left ventricular systolic function. Deformation analysis, longitudinal deformation analysis is the one that is most used, which is most reproducible, only analyzes the left ventricular longitudinal vector. Qualitative analysis. We are at the beginning of our examination in the parasternal long axis view, as you can see here in these different panels. There are a couple of things we can assess here, even besides evaluating the kinesis and the thickening of the anterior septum here and here, and the posterior wall. Look at the aortic root here in the upper left panel. This is a normal subject, normal systolic function, normal ejection fraction, and normal stroke volume. The whole aortic root in systole moves upwards towards transducer, which is up here. The extent of the movement from here to here is approximately 1 centimeter or more. Now look at this other patient on the right, which has a reduced ejection fraction and stroke volume. The root movement anterior movement upwards towards the transducer is much less. It's only a few millimeters. Okay, so compare the aortic root movement here, upwards, and here. Very different. What is the determinant of the anterior movement of the aortic root towards the anterior chest wall where the transducer is placed? Look at the video clip down here of a normal patient. During systole, the left atrium here fills, during ventricular systole, the left atrium fills and expands. The left atrium fills by an amount of blood which is the same amount which will enter in the following diastole of the left ventricle, and after that will become the left ventricular stroke volume. Remember that conventionally when we talk in physiopathology in general, speaking about the heart of systole and diastole, we always refer to the ventricular systole and diastole. So when I talk of the systolic filling of the left atrium, we are talking of the filling of the left atrium which occurs during ventricular filling, because that would be, in fact, in reality, left atrial diastole. Now, in this longitudinal parasternal view, the left atrium expands during ventricular systole mainly inferiorly towards the left ventricle and anteriorly, shifting anteriorly the aortic root. So the aortic root sits on the left atrium fills, expands, and shifts anteriorly upwards in the parasternal view, the aortic root. So it follows that the anterior movement of the aortic root is determined in systole by the amount of left ventricular stroke volume. If you reduce the velocity of the M-mode scan, like here, you can, like down here, you can appreciate this anterior movement. Again, this is a normal subject. You can appreciate it better. Again, compare here this anterior movement of the aortic root in this normal subject, as we said, with normal stroke volume, with this patient with severe dilated cardiomyopathy, severely reduced stroke volume. Look at the shift, the anterior shift of the aortic root. It's only a few millimeters, as we said, almost non-existent. Another qualitative estimation of global mechanical systolic function of the left ventricle is the early diastolic distance between the anterior mitral leaflet at the E point and the anterior septum, so the E anterior septum distance. Look at this clip. In a normal patient, you see that the anterior mitral leaflet at early diastole touches the septum. So the distance between the E point of the mitral valve and the maximum anterior excursion of the anterior leaflet and the septum, the distance is 0. Whereas the normal distance is less than 12 millimeters. Now, if you look at this other extreme case of extreme reduction of systolic function, you see that during early diastole, the distance between the anterior mitral leaflet and the septum, here in this case, is even more than 4 centimeters. And a third quality assessment is the systolic descent of the cardiac base, but we will talk about this parameter later on. Here are two M-mode examples of the mitral E septal separation measurements. The E point on the mitral valve M-mode scan is the maximum anterior movement during early diastole, during maximum opening. And then it's followed by the F point at the end of rapid filling. And then there is the A point, the anterior movement during atrial contraction. C is the closing point of the mitral valve. D is the opening point on the mitral M-mode scan. So on the right here, this M-mode scan of this patient, we have a normal mitral E septal separation of 80 millimeters of mercury, whereas on the left, we have an increased value of 15 millimeters. Now this is the same patient in the baseline here on the left with a reduced ejection fraction of 35%, as you can see here, and on the right, during medical therapy, we have a recovery of the systolic function, and you see the change and the decrease in the mitral E septal separation point. And this is the end of video number 2 about the echocardiographic analysis of left ventricular systolic function. Please proceed to video number 3, which will deal with left ventricular mechanical function and ejection fraction. And you are on the Echocardiography channel, a channel for cardiologists, sonographers, but not only, a channel dedicated to echocardiography in real-world analysis. And see you in the next video.